Kasab.
Sorry about that.
If you have a question you'd like to have Dr. Kasab address, we will be doing questions in the second half. And if you could put yourself on mute in the meantime, that would be really helpful so there's no background noise. And if there's something you didn't understand that she said or have a question, you can always chat to the whole group or to me directly. And feel free to raise your digital hand as well if you know how to do that. If you don't know how to do that, you can just go to your more settings and there'll be a little thing that says raise your hand. All right, Dr. Kasab, I'm going to turn it over to you at the moment.
Yes. Oh. So basically, we started again doing these study group sessions to have a common place that we can all come to and share our cases and share our struggles and basically learn more. It's all about that. So it's not a place to battle out a CO versus CR or neuromuscular or whatnot. It really, from my perspective, it really does not matter what modality you use finally to treat the patient. I think that if you're proficient and you've had great results treating the patients the way you have been treating them, just continue doing that. But if you are open to maybe trying some new things and some new techniques, obviously we'd love for you to try those too, because they work for, some other clinicians. So I do encourage everybody to take in this information and test it out for yourself. So where do we start basically talking about, TMD? So the general consensus out there is that, TMD is a difficult condition to train, to actually treat. And we have not been trained well in that in dental school. So all the education in the TMD condition, we have to obtain on our own. So that's what I did exactly. And actually, I got into TMD through orthodontics. And it was early on in my career. So I've been doing this for about 17 years. And I've had great experience with the way I treat TMD currently. And I train other clinicians who are having the same result. So today, what I wanted to talk about, so last session, we went into more just fundamentals and foundation of TMD. Today, I would like to talk about the difference between your regular night guard and treating TMD. So what is the main difference, right? So a lot of dentists may not actually understand. I wasn't taught the exact difference, what a splint is or what an orthotic is. I heard the terms, but technically, I did not know exactly what those things are. So what do? You revert back to what you know, which is we know that a night guard will help. And I think it's a great starting point. So I don't ever, down somebody for starting with a night guard. Night guards are great because it creates awareness for the patient that there is something going on. The problem will occur is that it does not actually treat TMD. It helps with some of the symptoms and the parafunction, but it does not actually treat TMD. So, and why is that? So let's review, why do we go ahead and suggest having a night guard for a patient to proceed with a night guard? Because typically we go into our hygiene a hygiene check, and we see that the teeth are severely worn, and we see that maybe some teeth are breaking. So for protective purposes, we go ahead and we say, you need a night guard. So this is where I feel like it's a great start, because if you can identify that and you ask a few more questions, the right questions, and that's what I want to talk about today specifically, I think you can get to treat a lot of TMD patients. So patients typically, I mean, they really, I don't want to say don't care, but they don't mind if their teeth are worn. And a lot of people don't mind that they're grinding and that they break an occasional tooth that they have to fix. Okay. That may not bother them. However, if you look at your patients and the patients that you are identifying as needing a night guard, you ask a few more questions. You will ask them, do you also have ringing in the ear? Do you have vertigo? Do you get headaches during the day, like frequent headaches? So the rule of thumb is that if you have 2 or more headaches per week, that's not normal. So frequency is a very important thing. So you want to ask, well, how often do you get headaches? What do you take for those headaches? So the difference is that when a patient needs a night guard, it's a parafunctional thing where you have hyperactivity. You just have grinding, underlying grinding, but a patient may not necessarily have symptoms from, and it is a form of TMD, but you may not have the symptoms to treat the case as a TMD case. So what do we do when we treat TMD patients? Exactly. So what we do, well, let's take a look at some x-rays. I think this will be the best way to lead right into that. So I'm going to share my screen. So let's see here. Window. Okay. Let's see here. Can you see my screen now?
It's coming up.
Mhm.
It's kind of just blank right now.
Okay.
You want to try sharing it one more time, please?
Yep. Let's see. Let's take a look here. To make sure that I'm on the right screen. So when I'm sharing window, entire screen. Okay.
Yes.
Share. Okay. Okay, very good. Okay, can you guys see it? It's my screen now.
Yep, we see your Zoom. All
Okay.
right, now we're getting there.
See now a folder with files in here, right? Liz,
Yes.
you can.
Yes.
So I'd like to start with what you will see during an exam, because this is very important. Not only are you looking at the destruction that has occurred inside the mouth, but I zone in right at the panorex, because the panorex is a huge telltale sign of what's happening. I can look at a panorex and tell you pretty much, like, clinically what I should expect to see. Okay. So even though the patient, there's a tab between the teeth and we tell the patient to bite down, they are biting at the same vertical and we tell them to bite right in the center. Okay. So this is still a good indication, because I get a lot of objections that, this is not their, CO bite. And this is a good indication of what is happening with the actual condyles. Okay. So when we take a look at the jaw, the mandible, okay, what we see is, like, right away, you can see that there is asymmetry in the lower part of the mandible, okay? And that is where that's like a telltale sign of what's happening. And if you ever take my course, like, we go into depth, but quickly for you to identify these, it would be looking at the center. Can you see my mouse, Liz?
Yes. Yes. Can you make the panorex full screen?
Thank you. Is that better?
Yeah,
And
there you go.
right? Yep. And I can actually zoom in because I think I should. Okay, very good. Thank you.
Yep.
All right. So yes, so first thing I do is I look at the center, okay? And if you just split this like visually, okay, what you see is that this side is like scrunched. It's scrunched down, okay? Where this side is looks longer, okay? You also see, so I'm giving you like the three things to look for, right? So we're looking for symmetry. Is it in the middle or not? And it's not in the middle. Second thing is one side longer in appearance than the other? And it is, okay? And then at the base here where you have the masseter attachment, we see overdevelopment of this ramus here, of this area, the angle of the mandible, okay? So what does this mean? Okay, what this means is that we have a like a hyperactivity of the masseters. There's a severe pull. So we know that soft tissue wins when we have, whether it's pressure or mainly pressure, the bone will respond because that's how we do orthodontics, right? We put pressure and the tooth moves out of the way. So and the pressure is done with elastics and things like that, and wires, and so that would simulate like the soft tissue. So when the muscle, being the soft tissue, is pulling and pulling and pulling, what it's doing is creating this little rounded, overdeveloped area here, okay? And the rule of thumb is that the angle here, the gonial angle, like this little dip here, should be no more than like 0.5 millimeters, dip. If you just take a straight line from GO to GN. So this is GN, this is the point GN from ortho, and this is the point GO from ortho, right? If you just take a straight line like this appears more than 0.5 millimeters. When you compare this side, this is a straight line here. But here you see a dip. The dip indicates that there is overdevelopment of the angle. Okay. So what should you expect? So this is what I look at, right? So this is a grinder that a person that grinds, okay, comes in with symptoms that I'm seeing. And basically, I'm looking at the Panorex, and I'd like to recommend a night guard. So you guys would recommend a night guard because they're complaining of grinding. But taking it a step further, having this indication that the condyles and the mandible is displaced. It's not, you can even say mildly dislocated because it's not in the spot that it should be, that we were born with. Okay, they should be symmetrical. So the masseters and the anterior temporalis muscles, they suspend the mandible in space, and they're supposed to be symmetrical in length. Okay, but God made us symmetrical, right side, left side. So when you see asymmetry, you have overacting on one side versus the other. So what I would expect is that there is joint compression on one side, okay, because this muscle is pulling and pulling and pulling, okay, and retruding this mandible back into the fossa, okay. And there is most likely some kind of disc, either displacement or it could be pain. So that's what I'd be looking for. So I would tell the patient, well, do you have any, are you experiencing any ear issues? So do you experience tinnitus? Do you experience any ringing on the left side? And when I say that, their like eyes open up, because nobody like just busts out and says that, to them. So they're pretty like impressed that like I'm seeing this, right? So then I just kind of follow up and say, well, your bite is one of those bites that the way that your bite comes together, it's just that bite that shows me that your jaw is moved over to one side and you would have compression around the ear causing symptoms. So having that link with those other symptoms other than just the ones for a night guard appliance, really gets their attention. And that's the things that I want you guys to like talk to the patient about and ask the questions. Okay, so what other questions should we be asking? Okay, so we have the vertigo. Do you get vertigo often? Do you get headaches? How often? Okay, do you have face pain on the left side? Okay, so those are all questions that I would just talk about. Do you sleep well? Because if they're retruded, so this, by the way, let's talk about the way that the condyle should look. So the condyle itself should look like a drumstick almost on the Panorex. So when you see that one looks like almost like a little, it's got a point, right? So when you see that, and then the other one has like a significant sloping, we call that. When there's a slope, meaning that when the mandible translates over time with the compression, it developed like almost like a ski slope, like a very distinct slope. It should be cushioned by the disc, and it shouldn't really change with time. When we look at young kids and their x-rays, it's a perfect little drumstick, right? I call that. And there's nice space in a joint, and there's mobility and very loose, right? But when we have compression in a joint, and this is retruded because the masseter is just pulling and pulling, pulling on one side, what happens is that this anterior area flattens. So it's like a flattening so that would be like a diagnostic thing, observation they would say about the Panorex that you are noticing. So I would say there is presence of left condylar flattening. So that's what I would just make a remark. Okay. And when over time, what happens is this slope actually becomes a little point, and that's called lipping. Okay. So if we have the flattening of the slope and lipping, okay, so that now we're talking about a more advanced situation. So that's probably like a class 2 joint derangement. Okay, so we have class 1, class 2, class 3, class 4. So there will be a class 2 with class 3 with the lipping then. Okay, and when you have osteophytes and arthritis here on the top of the joint, on top of the condyle, that would be like stage 4. Okay, so we certainly want to prevent that. So Night Conversation started to looking at the Panorex because what's the difference between placing a regular night guard versus an orthotic or a TMD appliance? The main difference is that we are repositioning the jaw. With a night guard, we are basically using the same occlusion and we're just opening that up, right? We're just creating a little space and a flat slope that they can just grind on instead of our teeth. Okay, it's a protective appliance. Here we are creating space. We are trying to put this mandible into the center, not where the teeth are coming together. So you have to imagine, get rid of the teeth. Teeth don't exist, okay? Like you get rid of the occlusion because the occlusion maintains pathology. So we need to clear that and basically start over. So create a new home for the mandible to occlude and function on so that these condyles will be in the center and there's space. There should be at least 2, maybe 3 millimeters of solid space around the condyle. And it's barely it's barely any space. I would say maybe a millimeter, less than a millimeter. Okay. So, and also the mandible is retruded posteriorly quite a bit. And this is like a painful area right here, if it's retruded backwards. This case actually is, from what I'm looking at, is bilaterally retruded, okay? But one is what came first, like the left patient's left side, this side came first, and then this is getting there, okay? Just from the way that this looks. Okay, let's look at another case. here we go. So here, this case is your classic TMD case. You don't even need to look at the patient and know that this is a TMD case. How do we know this? Okay, we know this because of the severely deepened curve of speed. I mean, this is almost a reversed curve of speed. Okay, so here the patient is biting on the stick to take the Panorex. Okay, so the condyles look like they're they're almost translating. They're towards the front, but literally, like if you take this little tab off and these teeth come together, look at how much vertical they lost, right? This is the vertical that you need to add right here almost. Okay, so if you have like, I don't know how many millimeters, let's say it's like 7, like literally you got to add that 7 millimeters to the back of the condyle, because this is how much that patient has to like function and translate back, okay, into occlusion. Okay, so that load would be right into the fossa on that patient. Okay, so I would just take a look at this and I would say, wow, if it's a new patient, if they've been coming to me, I would just say, I've been monitoring you over the years, and I just want to kind of touch base because, your bite is one of those bites that looks like you would have symptoms, and symptoms can come anytime. So I would talk to them about, I just want to ask you on your exam today, do you have any symptoms of ringing in an ear congestion without presence of infection? These are all medical diagnostic codes, by the way. Do you have headaches? How frequent? Do you have vertigo? Do you have neck pain? Okay, because a person like this typically has a significant head forward posture, which would affect their neck muscles and have a pain in the neck. So today we're just talking about like the difference between when would we say, okay, this is more than just a night guard. Okay, look at the Panorex. So the Panorex tells you like what you should see clinically, and then you ask the questions. So you have to ask those questions. Patients will not come in and say, I have ear issues, I have TMD, because nobody out there in the world really, there's like less than 1% of people that really are proficient in TMD in the United States as clinicians. So not a lot of people even link those symptoms with TMD. Okay, but it's one to one. It's a very related condition and symptoms. So so you just ask those questions, and that's when you would proceed to an orthotic, and then there's different designs. And again, it's you can practice. Everybody practices, what they feel comfortable with. So if your experience is, with a certain design and you've had great progress with that and a result, then you just keep doing that. But if you didn't and you want to try some other things, so there's a way that I do it that I find very useful, and it's predictable, I feel like, and it has great results. Okay, so then let's take a look at, just wanted to okay, so here is I wanted to show you a tomogram. So this is like a transcranial tomo, just to look at the joint, and it goes from closed to open and closed. So the other way. So it would be like closed, and then from right side, left side. So when you're taking this, and a lot of digital pans have this, utilize it, because I charge $480 for a tomogram, for a tomo x-ray. Okay, so you can go ahead and charge for this, and you should. So all grinders, like, you have to confirm what you're seeing clinically, right? So this and the Panorex is a standard of care. You minimally have to take a Panorex to treat TMD, but the second requirement is a tomo and then an MRI. So because I have a TMD and sleep clinic, I usually get a lot of patients that already had had MRIs because of the frequent headache. So they usually come to me with all that prerequisite, all that information. But if they did not, you typically, before you proceed with treatment, the protocol is that you should take an MRI to rule out any pathology, because there are things that will cause the same symptoms of headaches, and you guys know that. So I'm just talking about the protocol and the gold standard of care, right? So let's review the few things that I talked to you about the lipping and the changes in the condyle. Okay, so from this X-ray, you can actually see an additional third thing that happens with the condyle, and it's on the right side. Okay, so this will be like stage 4 almost of the joint derangement, and that is condylar bending. Okay, so we have flattening of the slope, the lipping, and the condylar bending. Okay, where the right side is still straight, it's not bent. Like this is a bend in the actual condyle here. Okay, so I would and this right here, this flat condylar head, okay, is basically, I would expect crepitus on that side. Okay, just because it's just so flattened, and there's not much cartilage at this point, probably right here. So yeah, so those are just the things that I'm looking at. And Liz, how are we doing on time?
You want to talk about the difference between your the night guard and the TMD orthotic?
Yes. And as far as
And then
design,
we'll go into questions.
as what should I cover first? Design or just in general? I guess just in
Yeah, in general.
okay, yeah. So so again, the night guard is more like a parafunctional appliance, where it's a protective mechanism to allow for a surface for a patient to grind on instead of your teeth. That's it. It does not actually reposition the jaw. In fact, if you put in a night guard in a patient that has TMD, it will allow them to pull and retrude. Okay. And patients actually complain about being in pain, because a TMD patient that has been retruded for a long time has very, very strong sternocleidomastoids, and as well as the anterior digastrics, and these muscles pull back, okay, quite a bit. So if you allow like disclusion, pretty much like a flat plane, you're allowing them to just slip and slide and go backwards, okay, and that is very painful to them because they're already in pain, usually right side, left side. So identifying the patients that you would typically suggest a night guard, and then asking more questions, to ensure that you're proceeding with a repositioning appliance like an orthotic. An orthotic, what it does is when we fabricate that, we actually take a different bite. Okay, so with a night guard, we just open them up and in CO, vertical distance of 3 millimeters or so, and they are we intend for them to bite into the same like central occlusion, okay, but basically with a 3 millimeter distance, right? Where an orthotic is fabricated with a different bite, and pinpoint contacts are created for that patient to have mandibular occlusion in a 3-dimensionally stable position. Okay, so there's a science called dental aeronautics, where it's the like almost like a plane, where it goes the roll, the pitch up and down, and the yaw. Okay, so the mandible in space can be displaced and repositioned in 3 dimensions. So how do you where do you put the jaw? Where do you put the mandible? Where is that neutral position where the muscles will be happy, right? So there's a whole science about how to take different bites. And, you guys know yourselves, like the CR bites, the CO bites, the tongue swallow bite, the neuromuscular bite. So there's all different methods of obtaining the bite. I find that the neuromuscular bite works the best. It's most predictable in my hands and my students' hands, and it allows for immediate myofascial pain, because the pain is coming from the muscles. It's not, by the way, it's not coming from the joint itself. If there is any pain in the actual joint, inflammation of the joint from capsulitis or tendonitis, okay, it's still soft tissue. it's not like the actual hard, like bone or anything like that. It's all soft tissue. So it's myofascial, like the muscles and the capsule and the tendon. So that's all the soft tissue that's causing the pain. So when we put that patient in a neutral position where they have space, the goal is to gain space in the joint and get rid of the compression, and then allow the muscles to just relax and suspend the mandible in space and be the same almost length and isotonic length. We know that muscles work best when their starting point is in an isometric position. So there is that engagement, and then you can go into hyper engagement, where like you see the muscle spasm. That means that the muscles are, like what we talked about, very scrunched on one side, and because the distance of the fibers is like shorter, they actually have more force. So there's a whole graph for muscle movement, and and I've studied. And so when you have that, you will actually develop lower face a hypertrophy of the muscles. And when I look at faces, I look for that. I see which side, let's say, is overdeveloped. When you have both sides overdeveloped, then you know that it's bilaterally retruded, and the distance of the muscles is shorter. Therefore, the muscle can really function, and the forces of the muscle is what triggers hypertrophy, okay, and the bulging of the masseter, okay. And then there's things that I train with Botox and other modalities. But the main difference between a night guard in closing and an orthotic is that the orthotic repositions the jaw, okay, and the night guard is just a protective mechanism for the teeth, and it allows for any pretty much jaw movement, okay. It is meant to provide a plate, like a plate for the teeth to grind on. That's it. So in a person that has pain, you don't want that. You want stability, okay, because the hyperactivity is what's causing pain and so on. So I hope I answered that question. So yeah, we can, I guess, take the questions now. So Liz, do you want to?
Can you stop sharing your screen, Dr. Kassab? There we go.
By the way.
We could see you before, you were just smaller.
Okay. Did I do it right?
You did. Sometimes you did it quite well.
Thank you. No, I just, because sometimes I think I stopped sharing, then I didn't. Okay.
Yeah, I do the same thing. So if anybody has any questions or specific cases or anything that you'd like to ask Dr. Kassab, please, feel free to unmute yourself. We're happy to take any questions that you have. In the meantime, if you are interested in really learning more about how to easily identify TMD, how to be able to support your patients, treat your patients, and really differentiate yourself in your marketplace, since, as Dr. Kassab said, very few doctors are putting this all together as she has. There is a training program coming up May 19th and 20th that we're happy to share information with you about. But if there's any questions right now, please feel free to ask.
Yeah, Liz, I see that Carrington Dental has a question. So
Can
let's
you hear me?
yes, we can.
Oh, okay. Hey, really quick, thanks for the overview. I learned a lot actually about negotiating attachment. I didn't know you touched base on the lateral pterygoid, because most of the maxillofacial surgeons and other people say it's the lateral pterygoid is where most of the issues come from. And when I actually press my thumb onto it, that's where it is. But yeah, I learned a lot and just in this quick meeting. So what I wanted to find out is that, do you guys have a workflow that, I think that makes, I know this is a study club, but say a new doctor comes in or other practices come on board, they don't want to sit there and like figure out, okay, it's okay, doing one thing, then doing another thing. They want to know, okay, I want to implement this thing and I want to invest time and money into this
Discipline. Yes, absolutely. Yeah. Yes, we
portion
do.
of sleep apnea, what portion is TMD, and a workflow on, okay, who's going to be responsible for what. So at the end of the day,
Absolutely. So yes,
as
absolutely.
we
So
spoke with, and I have a big Dr. Joy and I have a big following with our own blog that we do with other doctors in our area. So we're discussing this last night actually. And one of the things that we were discussing is that a lot of the doctors I found out it's not because they don't want to do it, is that they have been burned, the mature offices, okay? Not offices that are just starting out and all that, that don't know what the hell they're doing. We're talking about mature offices that have great what do you call pin pool, mature offices, and their population is aging and they need this kind of work, especially my offices. They definitely need sleep apnea on what you're discussing, but we are not going to engage. We discussed it as clinical directors of our practices. We will not engage with anything that does not have a workflow, and then who's responsible for each workflow, because what's happening is we have a lot of moving parts, and a lot of these doctors who are already at the mature phase of their thing, they don't want to deal with putting more things onto the plate of the staff. So they just say, you know what, I'm happy with what I'm making. I don't really care. I'm making good enough money. I don't want to go forward with it.
sure. So I'm going to okay. So I'm going to share this.
And that's where the disconnect is. The disconnect is doctors want a thing where, okay, what is the work?
Absolutely. I think,
and how is that workflow going to work, and who's responsible for each portion of that workflow?
okay, so let me show you our data gathering like sheet. Okay, so this is something that our patients basically are filling out. Okay, so when they come in, they go ahead, they put their demographics, their medical card. Okay, they
Dr. Kasab, did we lose your audio?
Yeah, I don't have her audio.
I guess while she's figuring.
exactly.
Oh, there you are. We lost your audio for a minute, doctor.
Oh, I'm sorry. Okay. Can you guys see my screen? I should make sure. Okay. So again, this is like something that I have a program that basically is like memorized on your iPad or whatever. You can just go to it, and then here's your comprehensive exam for your case. Okay. And I'm going to tell you why this is important, because when it goes to medical billing, everything you need is in this little thing. Okay. So okay, patient fills out their demographics. They add right here their medical and dental card. So it's scanned right in there. Okay. So they take pictures of this. Okay. They will talk about why are they coming. They will talk about, look, these are the symptoms that they have to identify. Okay. And these are all the symptoms beyond just grinding. Okay. Next thing, things that do not work for the symptoms. Okay, the reason we're asking all these questions is because this creates a medical letter of necessity. Okay, these things will populate into a thing that just creates a letter so that the medical biller just sends it. Okay, so you're
Don't tell me I'm.
and the clinical team starts here. So the posturagram, all the things that we want them to do before you come in. Okay, look at this clinical exam by Dr. Dorothy and the assistant. Okay, we do this together. Okay, then my diagnosis recommended. Everything I need is here. And when I click the button submit, that goes to the medical biller as a case. And we stop, the medical biller sends it in for a pre-auth, like a number, pre-auth number for the medical case, if the patient would like to send it to. But we collect our fee up front. But this is the workflow that you're talking about. It's very organized, and everything you need is in this one. You don't even need your software technically for this. And this can be printed as a PDF and can be attached in your software if you want. But because this is so different, like you're going to have 20 places that you need to gather your this and x-ray and all that stuff. The x-rays, actually, we take a picture of, catch it right here. Okay, to this sheet. The x-ray is right here. See, look, Panorex. Your remarks go here, but we area because they need to submit it with your case. So when you talk about workflow, I am like OCD organized. Like
I
like,
love that. I love that because that's what we want to do.
Yeah. Okay. So, and again, it's like it's a web, like you pull it up on any device, iPad, whatever. And then when it gets to the point for the examination, the patient stops, then the assistant. Very, very organized. The workflow is very organized. Yes. And this is what we teach, between the practice management and the course.
Hold on, Doc. Hold on.
Sure.
What's up, Atman?
Dr. Kasab, can you,
Yeah, it's not going to work, Atman.
I'm sure. Should I?
yes, you can stop sharing.
Because if you don't pass it, right? I know, but if you don't pass the thing, they'll put you into a microscope, like a thing, and they're going to tell you to do the alphabet backwards and upwards in numbers. So if you can't see through, then you're not going to be able to pass, and they're not going to give you the license. So you'll waste your time. So my suggestion is do it in granite.
Yes, I'm trying to. I lost my spot.
No, it's not about driving. It's about looking through the scope. It's like they want to make sure your vision is there with the glasses 20/20. So don't waste time. Just do it in granite, because if you don't pass, then you're gonna have to redo everything again. So you'll sit there for an hour, 2 hours in the stupid thing, and then if you don't pass it, then you don't get anything done. No, if you can't see with the thing accurately.
Dr. Nguyen, do you have any questions? I know you joined us a little later. Let's see. Oh. Dr. Nancy Nguyen.
And feel free to unmute yourself.
She's got her mute.
I was trying to unmute her, but okay. And I know we lost a couple of people early on because I don't know, my internet was going down today for some reason. And of course, this happens right when we have to start. So is there any other questions about cases, or do you guys have any cases? Do you have any questions? Have you had a case that you're like, what do I do here? Or something didn't work and why it potentially couldn't work? Usually that's what we talk about.
So one of the things is that how does your sleep apnea come into play?
Sure. Okay. So sleep disturbance is something that along with, so when I saw that case, that was, let me show you the case with this one. Let's see. I would immediately jump all over the the sleep apnea part of it. Okay, because usually class 2 retreated mandibles, like this one right.
All right, you know what? Yeah,
This-
I have another meeting. Okay, go ahead.
Yes.
So how can we get a workflow and then work with and find out what are the next steps if we want to have
Yes.
one of my, we're gonna do a beta test.
Sure. So what we will do is
So we're gonna do one office first and then see how that plow
Yeah,
like
sure.
into our office and then switch it to our specialty practice.
Sure.
So we want to start with one location, and then once that location is done, then we're gonna be not doing it there. We're gonna be doing it to our specialty office. So all the stuff. So if you can, someone help me, Liz, or email me, Liz, or whoever is there, to send me a workflow. And then once we know our workflow, because we want to make sure that's not TMD. We want to do sleep apnea and TMD. And I already know that I'm pushing more towards 60% into the sleep apnea thing.
Yes, but you're gonna find both. You're gonna find both when you
And
start.
maybe 30% into a TMD. They coexist, so we can double up on both things. If they can't get the sleep apnea thing, but at least we can give them the orthotic also. So I did a lot of thinking. Actually, spoke with the president of the Sleep Apnea Association, whatever they have, and he's an actually attorney. Actually, he doesn't practice anymore, but he used to do a lot of sleep apnea cases and TMD cases. And I spoke with him last night, and we went through some stuff about legal things, this and that, and that's another thing that we want to make sure that what is our liability when it comes to treating these patients also.
Well, exactly. And this is where the protocol comes in. I mentioned protocols here and there. So there's a gold standard of treating, sleep apnea, right? And so these are like the workflow for your team is going to be to ensure that, they get the PCP, that they get the sleep study or whatever it is that we need to obtain. It's following what other doctors like physicians would do for a sleep apnea patient. So you have to just adhere to the gold standard. And so this is what I teach.
Yes, there you go. That's what he said, that the thing is you have to follow what the American Medical Association and what those physicians do, and we have to translate that into our protocols.
Correct.
Okay. All right.
And we do this like all the time, you know what I mean? So
Right.
I will say when to stop, and you don't do anything until
Okay.
else. Or it's on you, because it's important. This is like we have to follow if we're gonna do.
All right. So if you guys or whoever it is, if you guys can send out a workflow of details so that way we know, okay, this is what's expected, and then we can work out, okay, what the next steps are to start implementing on Monday morning.
Sure. Yes, and you see, like all the doctors just have to, like understand like what we talked about, right?
Right. Well, Dr. Joe has done a lot of courses on TMD. He went to Pankey and all that stuff.
Right. Okay. All right. We will follow up with you. I know you have to go, so yeah,
He
we'll be in
said
touch
we can start.
next quarter. Every Friday. So bring your cases. So like next Friday, maybe have a case with us.
Right.
Okay.
But yeah. So meanwhile, I don't know who's going to be responsible for it, but you have my email. Send me the workflow.
I will do that. Thank you so much.
Thank you. Bye.
Hi, Nancy. How are you? Did you have a question? Hold on. Let me. You're muted. Could you unmute yourself? Can you, Liz? Can we unmute her somehow? Or
You should be able to, since you have the controls. Can you also stop sharing your screen?
trying, but it's not letting me for some reason. Participants, okay, and then.
Dr.
Okay.
Nancy, if you click on your screen, you should see a microphone pop up with a line through it. And if you just click on that, it will unmute you. Also, you may be able to just hit the space bar and hold it down while you talk. That should also unmute you.
Unmute. It's like it's not letting me do that for her. I'm not sure. Do you want to? Maybe you can even type your. Would you like to type your question and then?
Oh, yeah. phone is acting up. We've had technical difficulties this morning ourselves, so.
You see, like it's not letting us. I don't know. It's almost it's on her side. Because everybody else is unmuted.
Looked like it was for a second.
We're here. Allow, yeah, it says allow participants to unmute. Mhm. Oh, okay. So my admin team says maybe like exit and come in again. We'll readmit. Okay. Okay. All right.
All right. I'm just looking at what you had typed up.
Yeah, is there anything, did we leave anything out? So Sam is putting together, I don't know if you get a chance, for the level 1, level 2, level 3, she's putting all that together. We'll share that and with you.
Okay.
Okay, yeah, I'm not seeing her. There was a couple other people that were trying to get in. Will it show me who like was trying before?
I don't know what it will show you.
Something.
If you had, it may show you as you were trying to let people in.
Oh, okay. Yeah, because I was recording.
Like when you watch the video back.
Oh, admit. Here we go. Okay, now let's see. Okay, let's see. Connecting to audio. And let's see. It says connecting to audio.
If that doesn't work, there's always a dial-in number.
Mm-hmm. Yeah. What is that dial-in number?
I'll pull it up.
Okay.
I have many of them. I will actually type it into the chat.
Can you hear me?
Yes.
There.
I'm so sorry.
Listen, I'm like that too. Like technology, and then all of a sudden when you need to get it to work, it's like panic, because we can't get it to work. I'm so glad you could join us. How are you?
I'm good. I was just dropping off my kids at school and trying to listen at the same time.
Did you get a chance to listen to any of the beginning? We are recording. Send it to you.
No, I appreciate you recording it so I can listen to it now when the kids are in school.
Sure, yeah. So do you have any questions? Are you doing TMD? Is there anything that can help you? So we just run courses to help. That's all.
So I did the Vivos. Are you familiar with the Vivos stuff?
You know what? I'm not familiar with it. I've heard about it, but I don't know. I don't know much about it in details. You can share with me.
Their major thing is sleep apnea.
Oh, okay. Yeah.
And so their devices expand the jaw, and that's supposed to put the TMJ in the right place.
Mm-hmm.
So it's supposed to help with airway and TMJ.
Okay.
But,
I'm not familiar with that. So this, I'm not familiar with the technology, but I will certainly look into it. What I more of just your traditional way of treating TMD, but with a focus on myofascial pain. So I try to get the muscles in a state. I do use Botox, and we use appliances. We use deprogrammers and just traditional appliance therapy. But it's not familiar with, heard about it, but I have never used it. Have you used it before?
I have. So I have like 5 to 10 patients that are in the appliance.
Sure.
And I was wondering, when you are doing Botox, is that the same thing as Xeomin?
Yes. So yes. So it's a full. So Xeomin, Dysport, Botox, and Jeuveau all have that botulinum toxin in a
Okay.
form. What they do is they do different actions and derivative, and the way they isolate it that makes it proprietary to them, and they use. But what I found, to be honest with you, I've used everything. The most predictable one, unfortunately, is Botox. That's
Okay.
Hmm.
So what differences have you found between Xeomin and Botox?
Sure. The difference that I found is that patients like respond. So with Xeomin, some people didn't even respond. It didn't even take effect for them at all.
Okay.
So basically, I had to basically, like, you have to inject that, that cost, right? And work at all. I had to go back and do another treatment with
Okay.
So it's not fun. So I try to just stick to things that I know it's a lot cheaper. I do know that, but I just end up charging just what I need to charge the patient to just get a more predictable result. Because in the end, you're going to spend more, because you have to fix it, you have to give more, or, it's not working for them. So that was what and we used it for aesthetics too, or in my med spa for, crow's feet and 11 line. And then it lasts long enough. Like, a lot of patients reverted ready for the next injections within a couple months. That's not long enough, I feel like. It should be 4 months, and for TMD, it should be sometimes 6 months, depending on how much you give them, right?
So
And
is the
also-
company that DDS, they're the one that's promoting the Xeomin?
I have it through the medical side, the med spa, so I don't know the dental side who's promoting that. But I get it for the med spa. So it's through like McKesson, which is, the medical.
Okay.
I don't know who promotes it on the dental side, but the studies and everything, I don't know if they have even a approval for TMD, do they? I'm not sure, So Botox has the TMD approval, FDA, I'm sorry, FDA, not FDA approval for TMD. They have, so if you go off label, then, when we started with Xeomin, it was just when it came out. It was like a pretty new thing, a couple years ago, maybe 2 ago. And we bought a lot of it, so we used it a lot, but I just didn't find the results very consistent, so, and it was off the label at that point, but we just tried it to see what the results are,
Okay, that's good to know. For some reason, I thought they were the same thing.
Oh, no, not at all. No, because what they do, the molecules are different. They put in there the preservatives, no, it's not the same.
Okay, that's a huge pearl to know.
No, been there, done that, so we are, because I have the med spa cat, we're the center for a lot of devices here and on the side. So we have reps and pitching stuff to us all the time. So I'm willing to try it. And we actually did use it trial on patients just because we bought so much of it. I didn't find the results consistent at all. There was it's very consistent. Diluted the right way. And for TMD, even maybe concentrated a bit, it's very consistent.
Are you having any trouble finding the bacteriostatic saline to dilute it? No?
So again, I go through McKesson, so you may need to set up an account,
Okay.
and then the other pharmacy. Oh my gosh, no, it's what's the pharmacy that Jim? There's a pharmacy that we also go through for things that if they run out of. So I'll message you what the pharmacy is called. There's a pharmacy that you can set up an account, and basically whatever you can't get, you can get through them too.
Okay, great. And my phone, I had to go into settings under privacy mode and allow Zoom to go into the microphone. So it had nothing to do with Zoom. It had to do with my phone setting.
Got it. Okay. Yeah.
Okay,
Yeah.
yeah.
I have that on my, like, oh my gosh, where is that setting? Because I have to activate the microphone.
Okay, sorry about that.
Next.
Will you be emailing the recorded session today? Okay,
Yes,
great.
Put that email. Is it in here? Email? I forget how it works. Liz, how do we get the email? Do you remember?
Doctor, can you just drop your email address into the chat so we make sure that we have yours? I confirm that we have yours. So if you put it there, I know we'll have it.
Okay, let me do it now.
Yeah. Just drop it right into the chat.
Okay.
Perfect.
Okay.
Very
All right.
Yeah.
Are you guys offering any CEs that we could take?
Yeah, so we have a whole training for TMD and also practice management that goes into your office. So yes, so you can so also we'll share all the links and stuff like that. But yes,
Okay,
and
great.
hands-on. So like I train, how to manage the appliance, how to adjust it, how to take the bite, and all that. Yeah.
Okay, great.
Yeah.
Yeah,
So-
it's pretty heavy CE. Like our level 1 course is like 14 CEs. Just in that.
Yeah, and it's 3 levels, and each level has 3 courses. So it's depends, because a lot to know. We get you started. Usually students after the first session, they get going, but then we guide them through, in between sessions, right?
Okay. Have you heard of the AAFE courses?
Yes, I took those actually for both.
Okay.
Yeah, I like them, and they're run by I think they were created by a dentist, and then the lady too. So yeah, I highly recommend if you're going to do anything with med spa. I love their courses. I will review them for advanced cases. Yeah.
I did take 3 of their courses already. So I've been doing a little bit in the office, but that's why I didn't know about the difference between Xeomin and Botox, because the AFE promoted the Xeomin.
I know. And that's a new thing for them, actually.
Oh, yeah.
Yeah, that's a new, and what happens is the reps come in, they want you to try it, get a better deal if you promote it. So, but in my hands, I'm just saying, like, my patient's response was more predictable. Like I knew exactly I'm gonna give them this, and they're going to hyperactive spasms, where with Xeomin, like even the dosage was analogous, where with like Port and Botox, the dosage is usually like the same, the units you market differently, but you would give the amount of the actual Botox, right? Where Xeomin, it was like either a lot more, usually a lot more, or it just did not work at all. But that experience, and there could be another guy that liked it better, but our patients were coming back, too many times. And I was like, no, yeah.
Okay. Well, thank you.
The other one that's out there that you will have is I would, if you're gonna stick to anything, get the Dysport, or I feel like the Botox is most predictable. The Dysport is good when it actually works, but the molecules are also sizes. So I think that's what affects the actual outcome. So I've had some cases where it was not, not enough, like where it should have been, I felt, for a patient that I would have done with a Botox. But I have used Dysport a lot. Like that was our main product we used for a couple of years in the med spa. And then after all that, I said, you know what, let me just go to, like, I like things that are very like predictable and by the book. And once you get into education, you want to make sure things are FDA approved and, and it's like predictable. I want the students to feel comfortable. The minute you're going to have an issue, it's like you're going to get away from it because you don't know how to deal with that just yet. Right. So I try to put in place and teach things that I know are going to give you the result you're looking for more,
Yeah.
Yeah.
Okay. Well,
Do you have
thank you.
you have any cases that you want to share? Oh, 11. Okay. So maybe next time, if you would like to bring a case or two, then we can discuss it. So I typically ask for a Panorax, a tomogram if you have it, and your examination, just to give us some background, and then we can take a look at that, pictures, face pictures, and your diagnostic supporting documentation. And also if you have like questions like with bill stuff like that, we can try to answer those too. So
that would be just a screen share thing?
yes. Yes. And you can block out people's names if it's more about just the content, right?
I don't know how to block out people's name on electronically. So
well, you just move it up or down, like you can move it,
oh, okay, all right.
to put it over. Remember, I'm gonna
I think that the technology part would be the most intimidating, finding all the diagnostics and then sharing it.
Sure. So the best way to do that, I found, is if you have a snipping, so every window snipping tool, I just go snip, Panorex, next. Exams, clinical notes, snip, and then you just and then you just go through your snip. That would be the easiest, I'm thinking.
Okay.
Yeah.
Got it.
So
okay. Thank you so much for staying after with me.
Yes, well, I felt bad because we started like 10 minutes later and 2 people actually had to go. And so, because usually we have about 5 to 6 people every time. So, so it's fine. No problem.
So you're on the East Coast, right?
Yes. Yeah. Where are you?
I'm in San Diego. So I'm in the Pacific Coast. Yeah. And so,
start 7, right? So
right. So that's the time I'm like getting my kids up for breakfast and taking them to school. And so that's why I wasn't on video and I wasn't on the speaker. So I just wanted to hear you, but I couldn't actually participate.
Okay. Yeah.
Yeah, we'll be sure you get the recording.
So the study club is for an hour every Friday?
Yes, every Friday. So, and we like resume it and then we may take a break, like over the summer, like when people are busier. And then in the fall, we usually do classes. And then we resume like in the first of the year. This year we were building the curriculum because people wanted to have more on the aesthetic side. So Liz and I were building and the practice, and we added a bunch of stuff to the practice management module. So we started the study club a little late of this year. But I think it was worth it because like I think our content is so much more in detail and stuff like that. So
since the time is, on our West Coast time, do you mind if I just like shadow your study club and not really participate?
Oh gosh, absolutely. No, absolutely. Okay. Also, okay, you can communicate. So I'm not sure if you saw the little notice that comes out with the study club. You can email all of your information to Liz and with your questions, and I'll review your case.
Okay, great. Just do it beforehand.
Yeah, you don't have
you can submit it.
Okay.
which removes so much of the technology.
Okay, that sounds great.
Sure. And then we send them to everybody that was trying to participate and come in.
Okay. Maybe I can work on that today since it's my day off.
Yeah, sure. No, absolutely. Just anything. And then if you go TMD and sleep solutions website, there are links there to some of the courses that we provide. Okay, so it will give you an idea, like things that you can learn from us, if you're interested. So yeah, so feel free, and if you have any questions, contact Liz. I think I gave Liz's in the notice for the study club. So feel
And
free
Liz
to.
is gonna
Goes
email me
out.
anyway, right? And,
What's
and
that?
Liz, you're gonna email me anyways? For
Yes,
the,
we'll make sure it goes out in the email.
Yes,
okay.
all that in there for you.
Thank you.
All right.
Well, a wonderful.
Coming on this morning.
Thank you. You guys, you ladies have a great weekend.
Thank you. You too. Okay.